very simple diagram from an editorial published in 2007 that shows the pathways that we've been targeting traditionally in clear cell renal cell carcinoma, which focus on this VHL HIF pathway with angiogenic effector proteins, as well as the mTOR pathway. And what we can see here are the newly approved nivolumab and ipilimumab checkpoint inhibitors. Arguably, the most important driver of clear cell renal cell carcinoma is the hypoxia-inducible factor protein. It's a family of proteins, and we have HIF-1 alpha and HIF-2 alpha. This is taken from my mentor, Bill Kellen. There is also HIF-3 alpha protein, and he hypothesizes that whereas HIF-1 alpha functions to suppress kidney formation, HIF-2 alpha actually promotes tumorigenesis, and this is based on evidence including the presence of loss of function mutations in HIF-1 alpha. So the HIF-2 protein has been a very attractive target for drug development. And it's attractive not only because it controls VEGF and angiogenesis, which is the target of all of these drugs, but also because it induces cell proliferation, pluripotency, and it blocks apoptosis, which would be targeted by a HIF-2 inhibitor. The HIF-2 transcription factor is a heterodimer composed of an alpha subunit and a beta subunit. And this domain that you can see here, the PAS-B domain, is essential for dimerization. The structure of the domain was solved at UT Southwestern by Rick Bruick and Kevin Garner, and they found that within the PAS-B domain there was a small cavity, which they thought could provide a foothold for a drug. They did a screen and identified small molecules that had the ability to fit within this cavity and dissociate the dimer. That led to the foundation of a small biotech company across from the street, Peloton Therapeutics, which developed a drug, which I call here as a HIF-2 inhibitor. You can see here the structure of one of the compounds. This drug is predicted to bind to the PAS-B domain of HIF-12 and lead to the dissociation of HIF-1 beta. And we tested this drug initially in a platform in the laboratory with tumor grafts. And we have, over the course of the years, generated a large number of patient-derived tumor grafts. In this context, we take tumors from the patients and implant them orthotopically in the kidney of mice. This is a human renal cell carcinoma growing in the mouse kidney, and we have generated indeed over 100 lines. This is probably the largest tumor graft platform anywhere of these models. We previously shown that these tumors reproduce the histological appearance, gene expression, mutations in copy number alterations, and treatment responsiveness that we see in humans. And there was a high-profile paper from the Broad Institute challenging these models, and I can go over that if anybody's interested, but we think it does really recapitulate the biology of renal cell carcinoma. We previously showed that the tumors in the mice cluster with the tumors in the patient, which we find is a sign that they retain the identity exquisitely. So we use this tumor graft platform to test PT2399, which is the tool compound developed by Peloton Therapeutics. And this is just one example of what we do. We allow the tumors to grow. We don't cheat. So these tumors got to about 500 cubic millimeters. Then the mice get treated with vehicle, sunitinib, at doses that match human exposures, and then the HIF-2 inhibitor, and you can see the results here. And we did this for over 250 mice. Which were derived from over 20 patients. And we found that 50% of clear cell renal cell carcinomas were responsive to the HIF-2 inhibitor, here shown in red. And in many instances, these were tumors that were actually resistant to sunitinib. There were a group of tumors that were intermediate and a group of tumors that were resistant. When we put all the data together and we compared the effectiveness of the HIF-2 inhibitor compared to sunitinib, we found that the HIF-2 inhibitor had greater effectiveness and was also better tolerated, whereas the mice lost weight on sunitinib and the mice actually gained weight with the HIF-2 inhibitor. The only side effect that we observed in the mice was a reduction in hemoglobin, which is likely due to decreased production, and because the HIF-2 gene or the HIF-2 protein regulates erythropoietin. So this was an on-target effect. Interestingly enough, unlike the angiogenesis inhibitors that we have in the clinic today, this inhibitor specifically targets the VEGF and angiogenic pathway in the tumor, and that's shown in this slide. So if we look at the circulating human VEGF in the mouse, which is obviously produced by the tumor, we see profound suppression. But if you look at the mouse VEGF, it's unaltered, indicating that mouse VEGF is not controlled by HIF-2. but this also speaks to the specificity of this drug, which in fact does not cause hypertension and other problems that we see with TKIs in patients. We ask, and I'm not going to go over this into detail, but here what you're looking at are immunoprecipitation experiments of the HIF-1 beta subunit, and where we see that this drug in the tumors in the mice, the human tumors, is dissociating as expected HIF-2 alpha from HIF-1 beta, and is not affecting HIF-1 alpha binding to HIF-1 beta. So this is a very highly specific inhibitor of HIF-2. And we find that this dissociation occurs in both the sensitive as well as the resistant tumors. I won't go into this in much detail, but suffice to say that, when we asked the question, what happens to gene expression in sensitive tumors, we found about 500 genes that were deregulated by the inhibitor, but in the resistant tumors, there were no changes in gene expression, which speaks to the very high specificity of this inhibitor. Not surprisingly, we found that the sensitive tumors had higher levels of HIF-2 alpha, and you can see that here, these tumors in green are all sensitive. HIF-2 alpha is a nuclear protein. You can see the brown nuclei, whereas the resistant tumors had significantly less HIF-2 alpha and had higher levels of HIF-1 alpha. I'm having a little trouble passing the slides. This is quantitated over here. So we then asked the question whether resistance would emerge. And indeed, if we kept sensitive tumors treated with the drug for about 6 months and resistance did develop, resistance was associated with a reformation of the HIF-2 complex. And we found two types of mutations. We found a mutation, which is a gatekeeper mutation in HIF-2 alpha, and we also found a mutation in HIF-1 beta, which is a second site suppressor mutation at the interface between HIF-2 alpha and HIF-1 beta. So this data was the basis for a phase 1 clinical trial that was published in the Journal of Clinical Oncology a few months ago, and that Bob is also co-authoring. This involved 51 patients. The majority of patients had been treated with 4 or more prior lines of therapy, so heavily pretreated population. There were pharmacokinetic analysis and pharmacodynamic analysis that established 800 milligrams twice daily as the optimal dose. With respect to toxicity, as we saw in the mice, the drug was very well tolerated, and there were really only 2 high-grade toxicities, anemia and hypoxia, that were found in greater than 10% of the patients. And anemia did not require transfusions, and hypoxia was also symptomatic, both of them likely to be on target. There was a correlation between exposure and progression-free survival in the patients. And this is an example of a patient of mine that got treated with this HIF-2 inhibitor. And as you can see, this patient was in fact treated with the HIF-2 inhibitor for 1.5 years. All right, and let's see, looks like I skipped one slide. Okay, here we go. So this is what the data that we have with respect to activity in this phase 1 clinical trial. These are the 51 patients across the different dose ranges. And there was 1 complete response. There were 6 partial responses and 8 patients that remained on treatment for over 1 year. So this was a drug that had reasonable activity in a very heavily pretreated population, and which was tolerated very well. So just to conclude, HIF-2 is a valid target in clear cell renal cell carcinoma. Inhibition of the HIF-2 transcription factor abrogates tumor growth in 50% of human tumors implanted in mice, including tumors that are resistant to sunitinib, and I've shown you activity also in a heavily pretreated patient population. The HIF-2 inhibitor specifically dissociates the HIF-2 dimer, but does not affect HIF-1. And these downregulates HIF-2 target genes, including vascular endothelial growth factor. These HIF-2 inhibitors are more effective and better tolerated, I would say, not only in the mouse models, but also in patients. Primary resistance does occur, and it occurs despite dissociation of the HIF-2 complex, and acquired resistance also occurs and is secondary to the acquisition of mutations. We have a gene expression biomarker that we think could be predictive, as well as the levels of HIF-2 alpha. And I show you the results of the phase 1 clinical trial, and I have 2 seconds left. So with that, just to the acknowledgements. So the people in my lab that did this work were Wenpeng Cheng, Haley Hill, and Alana Christie. And we worked very closely with the investigators in the phase 1 clinical trial, including Kevin Corney and my institution, Bob Figlin, who is here, and then the team at Peloton Therapeutics. Thank you for your attention.